We're in Twin Falls, Idaho today, and we have a guest all the way down from Florida. I'm super excited. I've been talking to him before the show. And one thing I want to do today is I want to thank our wonderful viewers and listeners. I just got a message from a guy from Italy today. Lucia, I hope I am not murdering your name. He's a guy that watches from Italy, and he actually asked me a question about something that we're going to actually talk about in the show today about birth control pills and vasectomies. Welcome to our show.
Thank you so much for having me.
So tell us a little bit about your story. Where you went to medical school, where you graduated, did residency, all that kind of stuff. Tell us about your story.
Yeah, so I'm a first generation medicine practitioner, doctor in my family. I grew up in a very small town in Roscoe, Illinois, about 6,000 people. Neither of my parents were in medicine. I went through University of Illinois and then Rush Presbyterian Medical Center for college, and then medical school. And Rush is on the west side of Chicago. And then moved down to Florida, the Tampa area, for urologic surgery training in Tampa, Florida at USF. And then completed some research with Boston Scientific Research Fellowship, and have started to practice in the Tampa greater Tampa area. I guess be opening my own practice here shortly. In the Sarasota, Florida area.
You're looking at making some transitions in your practice right now. Is that correct?
Correct. Yeah, I used to work for a corporate hospital situation, and I'm going to be opening my own direct pay urology practice here shortly in the Sarasota, Florida area. Looking forward to it. Looking forward to kind of getting back to serving patients directly and spending the time that I need to spend with them, the time that they need to spend, doing whatever I can to add value to their medical care.
So tell us what this direct care thing you're talking about is. And we've had a lot of direct primary care physicians on our podcast before, but tell us what this direct care model and especially practice is like.
Well, it's a great question. I mean, there's not a lot out there, to be honest with you. I mean, it's again, like you said, it's a little bit more of a primary care phenomenon now. But the reality is I think that if you truly look at the financials of medical treatment, medical care these days, there is about a 34% surcharge in administrative fees on the money that you spend in your current care. Because of insurance and governmental regulations, and so that by that I mean 34% of your dollar actually goes somewhere other than, and actually it gets even higher than that if you look at truly what your physician is making, what your healing team is making. The physician is probably making about 7 to 9 cents. The healing team is probably making somewhere around 27% or 27 cents on the dollar of what you're spending in medical care costs. And so the direct pay model is really geared towards, number one, getting back to the value of the doctor, the physician patient relationship, and adding that and boosting that as much as possible. Because remember, right now, physicians spend probably 2 out of every 3 hours doing documentation and paperwork to satisfy insurance requirements, to satisfy different regulations that are out there. And so if I, as a physician, can cut out that extra 2 hours and cut out that 73% of the hours that I take and spend it with you, and also cut out that 73% of the cost and return some of that cost savings to you as the patient, and still deliver either as great or even greater care, then I think that holds huge value for everyone involved.
Yeah, for sure. And we had Dr. Lee Gross on last week, and he said basically the same numbers, that 70% of the cost of medical care has nothing to do with patient care. Only about 30% of it is really patient care related. So kudos to you for going out and on your own and doing this model, because the direct primary care practitioners, they will love that, because they always want specialists that they can refer to that they don't have to deal with all the insurance stuff, because they know that they're going to get better care at a less expensive price and possibly probably better quality. So and I know that just doesn't make a lot of sense to people, but that's why we have this podcast, is to educate and empower individuals that they do have options. And many times their insurance option, even if the insurance does pay, it's going to be more expensive that way with a copay. So going to somebody that doesn't even just skirts around the whole insurance issue saves them a lot of money. So I appreciate it. So are you ready to get into some clinical stuff?
Absolutely, sir. Let's do
it. So, okay, common question we get in our practice. So at Moses Lake Professional Pharmacy, we are specialists in hormone compounding. We do a lot of hormone balancing. It is over 85% of our practice. And my wife and I are both very passionate in it. My wife, of course, as your listeners and viewers know, is a pharmacist also, like I am. And we just have a wonderful team that just, we really focus on hormone compounding and hormone balancing. So, and one of the common questions, in fact, I got one today about this, is that we have a woman and she's on birth control pills. Typically, the average patient in this situation is in her 40s or so, and she's on birth control pills, and she's having hormone-related problems, i.e., she's not sleeping, i.e., she has decreased libido, i.e., she has vaginal dryness. All kinds of different symptoms that are related to hormone imbalance. And a question I will get is like, okay, when should we check her hormones? Or I checked her hormones, and here's what their levels are. And so first of all, if a woman is on birth control pills, in my opinion, a hormone test is a waste of time and money, because it is going to be totally skewed. Right. It's going to be totally skewed. So the first question I ask in those situations, because when they're that age and they're on birth control pills, I don't like birth control pills long-term anyway, because I see in my practice how often birth control pills, or not just birth control pills, but Depo-Provera shot, or Mirena IUD, anything that is hormone related to help with birth to be birth control. I see a lot of issues that it causes for women. So my first question is like, okay, why can't she go off birth control? So the common question is like, then I'll say is, okay, so is she in a long-term relationship? Is she married? Yeah, she's married and has 2 kids. Okay, so then my next statement is, okay, she's married and has kids and she's on birth control. Why? Her husband needs a vasectomy. All right, Dr. Wallen, go. Why should her husband get a vasectomy?
Well, I mean, I think the biggest thing is you kind of alluded to it already, right? I mean, the long-term side effects of birth control. I mean, remember, birth controls are usually composed of hormones like estrogen, progesterone, and basically what you're doing is you're blunting the normal cycles that women usually have. You're blunting nature, and you're basically kind of delivering them a more stable level, so that way they don't cycle like they usually would. And so that's why, usually at the end of these birth control packs, there's kind of a period of kind of fake pills that, basically allows the patient to cycle again and menstruate and slough off the lining and what have you. And so the reality is that, you're messing with nature, right? Already, we know there's long-term side effects. You've already listed them for us. The reality of why a vasectomy is such a great option is because, for the most part, it's pretty darn easy. I mean, yes, it takes, there is a little bit of recovery. There's probably about a 1 week period of no heavy lifting, no vigorous activity, no sexual activity. And you do have to stay out of anywhere where you're soaking your tiny little incision in water, like a bath, pool, hot tub, or what have you, until the incision heals. But otherwise, because of the fact that the testicles are external to the abdominal cavity, to the pelvis, and they're really just contained in a kind of a sac, for the lack of a better term, of skin, it makes it a very easy procedure. It's routinely probably about a 15 to 30-minute procedure in the office. Ultimately the patient is numbed. The patient gets some anesthesia in the form of Valium or other anesthetics like nitrous, where it's almost like laughing gas, right? Like a dentist uses to keep them very comfortable. A tiny little incision. It depends on which surgeon you go to, but usually it's either one tiny little incision in the front side of the scrotum, or maybe 2, one on each side. And basically all you're really doing is if this is the testicle, the little cord structure that comes down. Now remember that the testicles actually start by the kidneys when we're in utero in our mothers. And, usually by the time we're born or shortly thereafter, within the first year, they migrate into the scrotum. With that comes basically, blood vessel, artery, vein, and then also the little vas deferens tube. The vas deferens tube is the sperm highway. It carries sperm from the testicle to the prostate and seminal vesicles, where it's basically dumped into the urethra, and then that's how it's mixed into the ejaculate fluid. And so all we're really doing is kind of grabbing that little vas deferens, cutting out a piece. In my hands, I usually kind of cauterize both ends to make sure that the little tubes kind of can't come back together and reseal together, which is exceedingly rare, but has been documented. Right. And then I put a little suture stitch around one of the ends, and then do one on each side, obviously, to cut out, interrupt the sperm highway, and then that's pretty much it. You just have to couple little dissolvable stitches in the skin. And, a period of a time where the patient has to be careful because the one issue with vasectomy that does occur, other than, and actually the vas deferens, you could ask, how do you figure out which is the vas deferens, which is the artery, which is the vein? Well, the vas deferens is almost like al dente spaghetti. It's truly a hard kind of tube that you can feel easily and grasp. And so, from that standpoint, it's pretty easily identifiable. So there are always risks with procedures, but in the grand scheme of things, it's a pretty minor procedure to be done, and is usually, I think, by and large throughout the country, should be done as an office-based procedure, which, again, getting back to the cost savings, if you don't have to go to the hospital, if you don't have to use OR time in the surgery or in the surgery center, if you don't have to have an anesthesia provider, because we can do it with either oral sedation and local anesthesia, or inhaled anesthesia in the form of nitrous, then that is a huge ability to kind of save on costs for the patient as well.
Well, and convenience, and just going to a hospital period, there's just a lot of risk involved with that. Nosocomial infections, and that's very rare, but still, there's definitely a risk. So,
well, especially during a public health emergency pandemic, obviously there's a lot of people who have to be in the hospital for sick conditions right now. If you don't ever have to walk in the door, you're probably at much lower risk for being exposed to any of those things.
Okay, so I was listening the other day, and no scalpel vasectomy. I was trying to do that in my head. Yeah, you're laughing because there's got to be something that actually penetrates the scrotum, right? So tell us about that.
That is actually that's a very good marketing ploy.
Okay.
Ultimately, what a no scalpel vasectomy is, they don't use a scalpel, but what they do is they basically kind of grasp the little tube, because again, you can feel the tube through the skin. They grasp a little tube through the skin and kind of put a little kind of ring forceps around it and just kind of hold it in position. And then there's basically almost like a little spreader device that is actually a pretty sharp tip on it, and it basically kind of spreads the skin open. So yes, they don't necessarily use a scalpel, but the reality is that they still have to make a little cut in the skin to get the tube and to remove a little section of the tube and what have you. Whatever works, and again, it works for people, because again, anytime you don't have to think about scalpels or needles or what have you, again, it's one thing for me or other urologic surgeons to do these types of procedures, because we do them routinely every day, and to some extent, it's not us that's getting it done in those procedures, right? But for the average everyday person who most men don't want to see a doctor in the first place, let alone the fact that they have to have a procedure done, and then you start talking about scalpels and needles and all this stuff, and it's anxiety provoking. And so I think it's a good marketing situation to be able to kind of keep people at ease and more even keel, and not make it so much of a stressful process. But yes, they still have to do kind of the same general techniques, just with different instruments.
So what are some questions that you would ask a patient before you would give them a vasectomy? Like, age, if they had kids, if they're married, all that kind of stuff. Go through that with us, educate our viewers on that.
Right. So, the reality is anybody can get it done. There's not really any specific regulations as far as age-wise. Certainly anytime I talk to a patient about getting a vasectomy done, we always discuss the fact that in my consent form specifically says this is irreversible. And the main reason for that is because if you're already thinking about having it reversed, we really probably shouldn't be doing the procedure in the first place. Because although the reversal can be successful and is much more likely to be successful if it's closer to the initial time that you got your vasectomy performed in years. So if it's 2 or 3 years afterwards, it's much more likely to be successful than if it's 15 years after you got a vasectomy performed. But I mean, again, the reality is that if you're already thinking about having it reversed, we typically wouldn't do a procedure on you. However, obviously there's, many young men who say, I don't want to have kids, it doesn't matter for whatever situation. We understand that, again, I always counsel people it's irreversible, and certainly usually most folks get at least a 24 to 48 hour period, but between the consultation time and when we actually do the procedure, to be able to kind of perseverate on that a little bit and kind of just, be certain that that's what they want to do. Otherwise, certainly, like you mentioned, we do talk about, if they have kids, certainly if they have more kids, it's a little bit less likely that they're going to want it reversed in the end. But remember, there still is, somewhere between a 50 to 75% rate of divorce, right? And so, you talk about changing relationships and potentially your future partner wanting to have children or what have you, that could always come into play. Certainly marriage status isn't a requirement, but we do certainly usually ask those questions. But otherwise, it's really just kind of screening stuff about their health, and if they're on any supplements to make sure they're not going to have bleeding risks. Because certainly supplements like vitamin E, fish oils, some of these other things, anti-inflammatories like ibuprofen and et cetera, can certainly predispose you to have bleeding issues. And remember, again, one of the not necessarily common, but one of the problematic risks of vasectomy is if you get a little bit of bleeding in the scrotum after the procedure, that scrotum doesn't really limit it, right? It's kind of like an empty water balloon, and it will kind of stretch because it's extra skin. And so that can cause a patient's kind of recovery to go from, 1 week to, up to 6 to 8 weeks, or maybe even a little bit longer, just because if they end up with a little, kind of minor collection of blood underneath the skin. So we certainly are very careful about that. And that's part of the reason we aggressively talk to them about, no lifting greater than 10 to 15 pounds, et cetera, and usually use some form of jock strap and compression afterwards to kind of really prevent those things. But yeah, otherwise it's really just kind of talking to them about the procedure itself, putting them at that ease that we're going to do everything we can to keep it comfortable and make sure that they get an easy, gentle procedure, and we'll use numbing medications to cancel out any sharp pains. Again, usually I think it's, although I've done it with just numbing medication, I think most guys do a little bit better with a little sedative, an oral sedative. Again, to some extent, it's a little bit a psychological thing. It's seen, and you got a little bit of an extra kind of even keelness to you. That certainly helps, and that makes it a much easier procedure, both on the patient, but also, for me, because one of the problems that can occur is that if the patient's really tense, there are little muscles that regulate. Remember, the testicles kind of regulate up and down for temperature purposes to preserve spermatogenesis or preserve the production of sperm. And that's regulated by little muscles that are attached to the backside of the abdominal wall. And so if you're tense and you're really anxious, you kind of do these things, and I kind of have to do one of these things to be able to find food. And so we're basically kind of doing a little tug of war, but the tug of war is with your testicle, and that's not always the most comfortable thing in the world. So that's where, again, the sedatives or nitrous or what have you to kind of keep people comfortable and safe are certainly helpful.
So after they recover from the minor procedure, are there any sexual side effects like erectile dysfunction or lack of ability to orgasm, things like that? I you see that in the literature, decreased testosterone levels after vasectomy. Can you comment on those?
That's a great question. So the reality is I know there's even, actually, you didn't mention it, but there's even some literature that may suggest that there's potentially some small increase in prostate cancer if you have a vasectomy. Quite honestly, remember the hormones like testosterone don't even go through that tube, right? They don't go through the vas deferens. That's strictly a sperm highway.
Right.
And so they actually diffuse into your bloodstream through the little arteries and veins to the testicle, and actually kind of just locally can diffuse to the surrounding tissues as well. So unless there's some damage to the arteries and veins, and for some reason the testicle kind of shrinks up, which again is a very, very rare complication, then I don't see that the hormone imbalance is really truly holds much weight. I don't really think that the prostate cancer thing is all that valid. Again, to some extent, every time you see a new research study, there's always, findings, and to some extent, although it's not quite as sensationalized as the media, the snapshot at the top of the paper is always to some extent kind of provoking for interest, right? And so
Right.
the title, that is kind of provoking for interest, and so to some extent they get creative with those, but the reality is, I think that the long-term sexual side effects of vasectomy are significantly rare. There is some small subset, maybe less than 1%, where you get some minor testicular pain. The chance of it harming your erection should be almost non-existent, because we're not even anywhere near any of the nerves, arteries, or veins that control an erection. And remember, actually up to 85%, 90% of your fluid, the ejaculate fluid that is actually from the prostate and seminal vesicles, which is far away from where we're messing. So the only thing that really should be interrupted is no sperm in the ejaculate fluid, which just means no babies. It really shouldn't mean any other major changes to your sexual life.
Right. Right. That makes total sense. So thank you for clearing that up. There's a lot of information there. Wow, that was a lot there. So thank you so much.
Absolutely.
And so the next thing I want to move on to is unique treatments for erectile dysfunction. And let's just, before we go into those unique treatments for erectile dysfunction, go over your typical protocol consultation of what you would talk to a patient about if they had erectile dysfunction, and then your typical treatment, starting with the phosphodiesterase inhibitors, and then maybe prostadil injections, and then to the penile implant. So go through that about erectile dysfunction and some causes, because it's not always a physical cause either. So I'm assuming that you go into that.
Correct. So yeah, I mean, that's a great point. So I mean, the reality is, first of all, organically, the penis is basically an inflatable rod, right? So you need good blood flow in to fill it up and stretch it out, and you need little valves to close the veins to keep you nice and stiff. And that's usually a process that happens with stimulation that goes away after the ejaculation orgasm response occurs. That's natural for us. Unfortunately for men, usually that response is faster than women's ejaculatory or orgasm response. And so obviously there's a whole another subset of stuff we could talk about that, as far as stimulation of the clitoris and penile stimulation of the vagina really not being a great way to make a woman orgasm. But to circle back to the erectile dysfunction, certainly we talk about psychosocial stressors. I mean, if your relationship is not good and you're constantly fighting with your significant other, that's not going to help. Or if you're stressed out at work and because you got so much on your plate, and there's financial crises or what have you, all the different things that can happen in the world. Remember, what needs to happen in order for the arteries to fill and the stiffness to occur is that the blood vessels need to dilate, and so that way more blood flow can get to the penis in the first place. If you're stressed out and anxious and constantly under pressure or depressed or what have you, those blood vessels clamp. And so that makes it, certainly a situation where that makes it difficult for a good stiff erection to occur. And so that can be part of it. But beyond that, again, organically, we go through and talk about all the other typical types of medical problems that people have, whether it's diabetes or high blood pressure or any number of things, whether they've had prostate cancer surgery or bladder cancer surgery or bladder removal surgery, all these types of things, any type of pelvis surgery, colon and rectal surgery. If they have scar tissue disorders of the penis, like Peyronie's, where you get a little bit of curvature, that can cause problems with the little valves. But the reality is screening through all of that, plus also screening through all of the bad things that we do to ourselves, like smoking and alcohol excess use and drugs and these types of things. Also, certainly talking to folks about their heart function. A very common subset of patients that we see with erectile dysfunction are those with coronary artery disease. And actually, in fact, we know that through studies, we know that erectile dysfunction is actually up to a 3 to 5 year indicator of potential poor outcomes. And really the main way you can kind of think about that is that actually the blood vessels to the penis are about half the size as the blood vessels to the heart. And so, usually there's a lot of folks out there that have heart attacks or what have you, have coronary artery disease in the family. And so remember, in order for a blockage in your heart or your blood vessel to be significant, it has to be more than 70%. Well, that 70% blockage in your heart would actually completely occlude downstairs the artery to the penis, because remember, it's half the size. And so that's where we can kind of catch potential problems with the heart early, by kind of screening people and talking to them. That's why I always tell actually all the primaries I talk to, if you're not asking your male patients about their erection and you're not screening them for testosterone, we know that testosterone is also an independent risk factor for bad cardiovascular outcomes, low testosterone, that is. And so if you're not asking about those, you're missing an opportunity to catch these men early. And so we talk about all these things because, certainly even diabetes is very common, especially more common in our population as people get old. People get more and more obese, which our population seems to be doing, unfortunately. All of these things play a role, so we got to talk about those. We talk about all that stuff. We talk about, like you mentioned, the phosphodiesterase inhibitors, the Viagra, the Cialis, all the different medical pills out there that can be tried. Most of those basically just increase the amount of blood flow to actually most of your entire body, but also specifically geared towards increasing the blood flow to the penis and to kind of increase the pressure. Remember, more volume equals more pressure equals rigidity, right? And so that's the goal in terms of an erection. And so that's usually the first line, but also remember, we talk to people about behavioral characteristics. So, following a heart healthy diet, low salt, low sugar. Actually, nowadays, the American Heart Association says a plant-based diet is the best thing for your heart. Well, guess what? It's also the best thing for below the belt. And so, from that standpoint, we talk about all those things. We also talk about the fact that they recommend, upwards of 30 or 40 minutes of cardiovascular activity every day. Not every day, but I guess they used to be 3 days a week. Now they say at least 5 days a week, right? So pretty much every day.
Right.
And so from that standpoint, getting active and not being sedentary and, getting home from work and just basically being kind of a slug on the couch. Obviously, that's not a good thing for anybody. And so certainly, again, that does play a role in your hormones, right? If your hormones are low as you get older or for whatever reason, you're going to be fatigued at the end of the day a lot of times. And so making sure we check your hormone levels is very important. And so we talk about that. We go through, again, the oral therapies. It's usually first line, although now Society of North America, I should talk to you about every single treatment and give you the option, because again, it's patient-centered therapy, right? So if you've had a prior prostatectomy for prostate cancer surgery, quite honest with you, even if you had what's called nerve-sparing surgery, which means that they kind of swept away the little nerves at the bottom of the prostate that usually control erections when they took your prostate out, there's still an 80% chance you're never going to have an erection hard enough for penetration. And 80% of those guys are going to fail oral medications. And so from that standpoint, the next options are a couple of things. One, there's a vacuum erection device that basically kind of slides over the top of the penis and is usually used in conjunction with a little ring at the base to kind of basically, number one, pull blood into the penis, but number two, kind of trap it there, kind of artificially recreating the valve and artery structure as the penis usually has. I don't find that a whole lot of people really love that option as far as an actual treatment, just because it's not as natural, but it's an option. Beyond that, there's little tablets or little gels that you can squeeze into the urethra, and that basically diffuses the medications to the penis. Or as you mentioned, the little injections that go directly into the side of the penis that basically deliver all of the signals for an erection to occur. And so they basically bypass the brain and the spinal cord and et cetera, and kind of recruit as much blood to the penis as possible. That is the one form of erectile dysfunction medication that could potentially lead to this 4 to 6 hour or longer erection that you may hear about on TV ads or online or what have you, what's called priapism. That's actually an emergency, and you should, if you do have an erection that lasts longer than 4 to 6 hours, you should get to the nearest care department, whether that's an emergency room or what have you, because basically what happens is that the blood flow to the penis and specifically come to the end really kind of stops. It's kind of a static state where there's no oxygen or no nutrients coming into the area. It's not super common, but it is a little bit common, especially if you get into higher doses of those injections. It's about 10% chance. Beyond that, as you mentioned, the penile implant. The penile implant, for the lack of a better term, the best way I can describe it to people to make it easy for them is basically a new inner tube for your tire, so to speak. And so if you, and I guess, whether your arteries are slow and you don't get much blood flow to the penis anymore or not, or alternatively, whether those little valves don't close as much anymore. Again, remember, there's commonly a couple of groups, Peyronie's disease patients, that's that curvature of the penis, diabetics, patients with prior pelvic surgery, like I mentioned, prostate cancer, bladder cancer, colorectal cancer, et cetera. Or smokers, they tend to have valve dysfunction or venous dysfunction as they get older, and or after their treatments. And so remember, the valves, the best way I can describe it to folks is no matter how much you pump up your tire, you still kind of have a little hole in your tire, and it really just never gets quite as hard as it used to. And so the penile implant is basically a minor outpatient surgical procedure, done usually through a tiny little incision just above the top side of the penis. And basically what it is it's a 3-piece system that's fluid hydraulics. So it's filled with sterile fluid. And basically the 3 pieces are connected in the OR during the procedure. All of it's hidden underneath the skin. You can't see any of it. But what it is it's a little manual system that's used through a little pump that's in the scrotum that basically is kind of like the old Reebok shoe, where basically, you kind of squeeze it and it transfers the fluid from the little reservoir into the cylinders and recreates that. Remember I said in the penis, more volume is more pressure is rigidity, right? And so in the penis, when the more you pump that little pump, it transfers the fluid from the reservoir to the little cylinders that are in the penis. And basically that creates the rigidity. And so that's been a very kind of revolutionary thing since even as recently as the 80s is when that was kind of really came onto the market, and has been a beautiful thing for a lot of folks who otherwise, whether they're, coronary artery disease is a very common problem in our patient population in the United States and in the world in general. And, remember, even if you have to start a blood pressure medication and we dropped your blood pressure 10 points, there's actually some good data that shows that if we drop your blood pressure 10 points with a blood pressure medication, it's likely going to harm the rigidity of your erection. And so at some point, a lot of patients I see come in on 3 or 4 blood pressure medications, not just one, right? And they used to be 180, 190 systolic, wow. And now they're down in the 120s, 130s, and they're wondering why they can't get an erection. Well, think about it. If the pump is damaged to the point where, you really have to kind of take off the, maybe not take off, but maybe more like put the training wheels back on and kind of keep it to a little bit less of a more regulated situation. Trying to be able to kind of inflate the penis for an erection, it becomes much more difficult.
And that's why their body was compensating with pressure anyway, just to get blood flow to the extremities, pretty much.
Correct. Because remember, blood flow is usually either the pressure from the pump or the resistance from the system. And the resistance from the system is the way that they kind of usually drop the drop the blood flow or drop the blood pressure one of the ways anyway. But yeah, you're right. I mean, if it's one of the compensation mechanisms. So the penile implant is it's a nice procedure. It's actually 60 to 80% of guys are still functional 15 to 20 years later with their device.
Wow.
And the satisfaction rates are super high. I mean, 90+% for both patient and partner for that surgery. And again, the reality is it's all it is a fluid mechanism through a combination of a couple little pieces that basically allows you to recreate the stiffness. It should not harm your ejaculation. It should not harm your orgasm. It should not harm your sensation, at least compared to where you were before the procedure. And so, obviously, if there is some dysfunction there already, we're not going to fix that by doing a penile implant, but we are going to fix the erectile function. And, it can be a very long-term solution for many, many patients. Again, I already mentioned, I didn't mention this part, which is 50 to 90% of cancer patients across the board, both men and women, have sexual dysfunction at some point, either during their treatment or afterwards, right? I mean, whether you get surgery, whether you get chemotherapy, whether you get radiation, all of these things are meant to damage our normal cells. Well, they're not meant to damage our normal cells, but they're meant to either damage the cancer and remove it or what have you. But unfortunately, during that process, there is some significant dysfunction that can occur to our normal tissues as well, right? So
Absolutely.
Especially if you end up with prostate cancer. I mean, I've seen guys as young as, I think the youngest guy I saw, I want to say he was 38 and needed a prostate cancer surgery because he had some kind of aggressive looking prostate cancer in his prostate. At 38, if you end up having a surgery and you have an 80% chance you'll never have an erection hard enough to penetrate again, and no matter how beautiful your wife is or what have you, your partner, unfortunately, that's a pretty long time to live the rest of your life with less of a quality of life. I wouldn't say no, because obviously there's a lot of things outside of sexual intercourse that can lead to quality of life. But if you're going to be around and we cured your cancer, personally, in my hands, I would love to restore your quality of life, because in my mind, that's part of the reason you're here, is to enjoy the time you're here too, right? So
yeah, and it is very important. I mean, sexual health is very important. And sexual health in a relationship is very, very important. And really, not even if you're 38, but even if you're 70, it's still important, right?
Correct.
Yeah.
We've implanted guys as old as 80 plus. So
Oh yeah, yeah. I was reading.
Again, the procedure, even that procedure, is somewhere between the order of 30 to 60 minutes for the average, kind of first time procedure type thing, without any major kind of curveballs, I would say. But so the reality is in the grand scheme of things, if you can tolerate a short procedure with anesthesia, that opens the door for many more people to potentially have, these types of things done. And remember, actually, last year, I think probably about 2,000 men in the United States had this procedure done. But remember, last year, about 20,000 women had breast implants. And so there's a huge gap there where we're missing to be able to educate men. And I think it goes back to a little bit about, men don't necessarily seek care quite as much as women do. But to a large degree, if you look at it, the only main difference I see between the two is that, actually a penile implant is actually functional. Whereas a breast implant just kind of sits there and hangs around, the penile implant actually moves up and down and it has, mechanisms of function. And actually, there's two main companies in the United States that make the devices. One of them is working on, because obviously, you start talking about these older patients. And again, I mentioned you kind of have to, do some pumping to be able to inflate the device. And one of the things that happens as we get older is our dexterity doesn't always stick around so well either, right? So there's actually one of the companies out there that's working on a Bluetooth technology to be able to kind of activate it with either your cell phone or with kind of like your car beeper, boop, boop, be able to do that. And so that they're looking at releasing that within the next couple of years. So that will be kind of the next advance to be able to kind of offer this to more folks and not have to limit people.
Boy, that has some interesting implications if your partner gets a hold of that phone.
Yeah, or if it gets hacked, right? If it gets hacked by some hacker. All of a sudden, we got these people walking around.
Oh my gosh, that's hilarious.
It's interesting that you mentioned it, because the reality is, I even mentioned that in discussing this device with or that technology with some folks, and it's actually the same technology they use for heart defibrillators, right? And so
Oh, okay.
those obviously have to be much more secure, much more ability for nobody to be able to mess with it, other than the people that really need to be able to adjust it. And so they're actually able to use the same technology as that to be able to make sure that it's secure and make sure that nobody else can kind of kind of mess with things without your permission, so to speak.
Right, right. So, speaking of sexual health, and we talk about it often in our pharmacy because hormone balancing is part of that a lot of times, and the subject of sexual health always comes up. I was just reading Suzanne Summers' book the other day. Suzanne Summers just put out a recent book. I can't remember the name. Producer, if you can look that up, her most recent book, and we'll talk about it. But she is 73, and her husband, who she's been married to for over 40 years, is maybe over 50 years, is 84, and they have sex twice a day. So
Right.
yeah, so the concept that sex is over when you're 60 or 70, I mean, it's just absolutely not true. And so I appreciate you giving your expertise today about those issues, because it's important up until the day we die, possibly, for
Right.
many people.
Again,
So
it goes back to quality of life. It's not everything, but it is a component of it, even just for stress relief, mental health, what have you. And remember, the reality is before kind of modern medicine, modern times, where I think it seems like you're very well versed in hormone replacement and the need for it. Quite honestly, I think what has happened over the years is that we have used a lot of pharmaceutical medications to treat the symptomatology of hormone loss, right? And so if you were up here when you were 20 and 30 and you start to do a little curtail and kind of slide down on your hormones, and we start adding a blood pressure medication or adding this or adding that, instead of actually stepping your hormones back up to where you were, even for women, estrogen is huge for vaginal dryness and
oh yeah.
preventing
Yep.
UTIs and this type of thing. And if you lose that estrogen, and we just try to throw something on top of there as a band-aid rather than giving you back your estrogen, I mean, part of the reason some older women don't necessarily like to have intercourse is because they've been without estrogen for so long that their vagina is atrophic and it tears and is dry, like you said, and obviously that's a huge problem. But if we can restore their function, I think there is a good amount of quality to be gained with that.
So let me tell you, as much women's health as we do, and our number one prescription is estriol vaginal cream
Yep.
for the reasons you say. And by the way, we were what was her book's name? Suzanne Summers' book's name? A New Age. What was that? I want to mention her. I want to mention the book's name for our listeners and viewers. We were streaming the title there. A New Way to Age: The Most Cutting Edge Advances in Anti-Aging. So she's written a lot of books, and some are controversial. Maybe a lot are controversial, but that's okay. I think there's some good information in a lot of them, or a lot of good information in them. So, anyway, estriol vaginal cream. I personally believe it's our number one prescription in our pharmacy. I personally believe that every postmenopausal woman should be on some type of vaginal estrogen cream, because if they don't have atrophic vaginitis now, they will, and that's usually the first symptom they get. If they don't have chronic UTIs, they will, and they will have urinary incontinence too. How many patients, Dr. Wallen, are in a nursing home and they're on ditropan and they're on nitrofurantoin for urinary tract infections and for urinary incontinence? And you know what? They don't lack those drugs. They didn't have those problems in their 30s. And it's amazing to me. I got to be honest with you, Dr. Wallen. There are urologists that don't get that concept, and I have to educate them. It's like, well, that's your first go-to. Why don't you think about, your ditropan is your first go-to. Why don't you think about why they have urinary incontinence? Let's treat the problem, not just the symptom. Let's fix the problem. And obviously, you fix the problem with topical vaginal estrogen cream. you fix so many other problems. So yeah, I think every postmenopausal woman should be on some type of vaginal estrogen cream. So thank you for that information. Now, going back on hormones. So you mentioned this, that if you're not checking a man's testosterone, then you're definitely doing him a disservice, because you're missing a lot of things, because low testosterone is an indicator of cardiovascular. I don't want to put words in your mouth. I remember what exactly you said, but it's an indicator for cardiovascular risk. Is that what you're saying?
Risk factor for cardiovascular problems.
Okay, perfect. Thanks for clarifying that.
In the American Urologic Association guidelines nowadays, actually, I mean, you probably know this as a pharmacist. You know, recently, as recent as 2015, there was a black box warning on testosterone that said, if I give you this, I got to tell you, it could potentially cause heart attacks, strokes, blood clots, what have you. And the reality is that the urologic community since then has done a ton of research and actually proven that to be false. And some of the early studies were flawed. But the reality is that low testosterone is an independent risk factor for poor cardiovascular outcomes.
Okay, so what you're telling me is testosterone does not cause heart attacks. Is that what society said that?
The American Urologic Association in the Sexual Medicine Society of North America
says testosterone does not cause heart attacks. Perfect.
Yep.
Thank you for clarifying that, because I get that question all the time.
Yep.
And myself, even before, another study came out with that follow-up about, when testosterone caused heart attacks, to me, it wasn't rational. It didn't, because if testosterone caused heart attacks, then 19-year-old men would have heart attacks, right?
Correct.
I mean, that's just rational thinking right there, when in reality, most men that have heart attacks have low testosterone. That's just so, and there's a lot of factors there. We could actually have a complete episode just on that. Yeah. I believe what it is, a lot of times when those men have a heart attack, whether they're on testosterone or not on testosterone, because testosterone is cardiovascularly protective. Right. They've had low testosterone for 30 years. The damage has been done. So even if they go on testosterone when they're 70, the cardiovascular damage has been done. That's my opinion.
Right. Well, and remember, the heart is a big muscle. What's better for a muscle than testosterone?
There is no better
than testosterone for a muscle. I don't know it, to be honest with you. I mean, and to some extent, remember, testosterone plays a role in your lipid profiles, right? So
absolutely,
there is some evidence too that suggests that replacing testosterone can essentially kind of, restore normal lipid profiles, and also kind of remove over time, right? Not right away, but over time, remove some of the plaque buildup that kind of clogs up your arteries, right? And so that's what causes heart attacks in the first place, is that clogging of the arteries and the plaque buildup that leads to ultimate blockage and lack of blood flow. And so, and the other thing is that, one of the other risk factors for heart problems is hypertension, right? High blood pressure. And there's some decent research that shows that, testosterone can kind of significantly change your blood pressure parameters to the point where, I know folks that are pulling people off of blood pressure medications after they, restore their testosterone and get them back to a more chronic, normal level. Take it one step further. Remember, diabetes is a huge cause of coronary artery disease, vascular disease, et cetera, vascular dysfunction in general. There's a study out of Germany where they had about, I think it's just shy of 500 patients who were on everything from metformin to full dose, injection insulin. And when they screened these men, they found, that a certain amount of them were hypogonadal as well, or testosterone. And when they replaced the testosterone not right away, because again, diabetes doesn't develop overnight. It doesn't go away overnight either. But not over a period of time, with chronic testosterone therapy and replacement to a normal level, about 30% of the patients in the study actually reversed their diabetes.
I've seen a study like that. Yeah. Right. And you just think about all the drugs that we prescribe that could be, if we check the man's testosterone, it could be low testosterone related. Viagra for erectile dysfunction. Did you check their testosterone? No. Prozac for depression. Did you check their testosterone? No. Lipitor for high cholesterol. Did you check their testosterone? No. I mean,
is To your knowledge, because you may know more than I do, but to your knowledge, any of these newer diabetes medications on the market do any of them have the potential to reverse diabetes?
Absolutely not. In fact, Dr. Wallen, I will be honest with you. In general, and I can speak for my wife too. In general, I don't believe in any. I don't care what medication it is. For type 2 diabetes, I don't believe in any long-term treatment for type 2 diabetes for medication.
Yeah.
Diabetes is in general, type 2 diabetes is a lifestyle related issue.
Correct.
It is a carbohydrate metabolism problem. Usually with type 2, obviously it's hyperinsulinemia. You have too much insulin because you're eating like crap, usually too much carbs, too much processed foods, you're producing too much insulin. So then what do? We give patients more insulin. Or what do? We give them a drug where they pee out their extra glucose. To me, that one doesn't make any sense either. It's like, and then it's like you pee out your extra glucose, and as you use urologist, I'm sure you've seen a lot of this. And then all of a sudden you get UTIs. Really? Now, why would that happen?
Right. Well, and
So,
take it one step further, you mentioned some benefits for men for, brain health and heart health and insomnia and erections and stuff. But what's the other most common problem that older women have as they get older and go through menopause other than UTIs? It's bone
osteoporosis.
health, right?
Osteoporosis.
Right. So
Yep.
testosterone is known to be a bone builder. And you can actually, there's some studies out there that show that you can actually increase new bone growth by 8 times with testosterone replacement.
Well, this is what I tell women, tell men too, because as you know, men get osteoporosis also, not as common as men, or not as common as women, but it's not from lack of estrogen. It's not, and not that men don't have estrogen, but it's not from lack of estrogen. It's not from lack of a progesterone. It's from lack of testosterone.
Right.
So, and women, how many women are on medications, Fosamax or what have you, for osteoporosis, and we keep it on them for the rest of their life, which there's a lot of debate. I'm not a big believer in those medications because they will build new bone, but it's brittle bone.
Right.
And if you don't believe that, then think about when you go into the dentist and the first question they ask you is if you're on those medications. They will refuse to pull your teeth because your jaw will shatter.
Right.
So if it's making weak jaw bones, it's making weak femur bones also. So I think testosterone, it's a lack of hormones, right? And I think estradiol and progesterone also, because those are in the bone remodeling process also.
Correct.
But there is not a better hormone than testosterone to build bone. It is an anabolic hormone, right? It builds muscle, it builds bone. So testosterone is amazing for that. And that's why when, women are being talked to about possibly going off their hormone replacement, I'll ask them about their bone health. Well, yeah, my bones are better now. And I'm like, okay, so how long would your doctor keep you on a medication for osteoporosis? Well, probably the rest of my life. Okay. It's kind of like estrogen vaginal cream.
Right.
Well, when do I get to go off this? I tell them, I'm like, you're not going to magically start producing your own estrogen. So if you want to prevent UTIs, you want to prevent urinary incontinence, and you want to prevent atrophic vaginitis, you'll stay on this a couple days a week for the rest of your life.
Right.
So, and we've got 89-year-old women on estriol vaginal cream. So I love your education on testosterone. I can tell you, you are ahead of most physicians that we work with when it comes to testosterone replacement, because that's not a view in most people in traditional type practices. And that's probably a sign of why you're going on to practice on your own, because you felt like you could offer patients better than what you're doing. So I'm not surprised.
You're talking about, the opioid crisis, right? A lot of pain related symptoms are bone pain. And I mean, Larry Lipschuld's group out of Baylor, they showed, you can reverse about 50% of bone pain by reversing someone's hypogonadal status, reversing their testosterone, right? So,
well,
I mean, that's a huge way to avoid some medicines that have significant side effects and significant problems, addictive side effects or addictive problems. And I mean, by just giving someone their natural hormones back.
Absolutely. You're preaching to the choir. I love it. So another question, when we talk about hormones a lot, we talk about, for men especially, and testosterone for men, we always get the question about PSA.
Right.
So I haven't asked you this question before the show, so I have no idea where your answer is going. So talk about PSA. I have some strong opinions about PSA, and I have some questions I'll ask you. So go ahead and tell us about PSA testing.
Well, I mean, PSA testing, I think, the reality is that it has been called into question. As recently as a couple of years ago, the USPTF, downgraded it to a Class D. They've since re-upgraded it back to a Class C, where they recommend screening. And I think the reality is what you have to understand about prostate cancer is that prostate cancer does not usually cause symptoms until it becomes symptomatic, which means or excuse me, let me rephrase that. It does not usually cause symptoms until it becomes metastatic, which means that it's spread beyond the prostate.
Right.
Sitting in the prostate, it can smolder and smolder and smolder, but until it attaches to a bone or does something else, in the pelvis where there's lymphadenopathy outside the prostate and maybe it's entrapping a nerve or something like that, it does not usually cause other symptoms. And so unfortunately, the PSA is not perfect. There are other things like a large prostate. I mean, we know that men's prostates literally get bigger as they get older. That also correlates with PSAs going up with prostate size. But there are also other things like urinary tract infections or prostatitis, or even if you've ejaculated within 2 or 3 days before your blood test, that can cause the blood test to be elevated.
Okay, can we hold your thought where you're going? I want to hit on that, because I'll have men that will call me and they'll say, well, my PSA went from a 1 to a 5.
Right.
And I'll ask the question. It's like, okay, so when did you get tested? Well, I got tested, early in the morning. Well, did the doctor ask you about, your ejaculatory status? No, he didn't. Well, I had sex with my wife that morning. I'm like, I'm not a doctor, but I will tell you that, ejaculation can affect PSA. So for them to recommend a prostate biopsy without asking that question,
Right.
I think I don't know what to call it, but I just don't think it's given the whole picture. So can you comment on that?
Yeah, absolutely. So, I mean, I think remember, especially in the traditional medical model where you have to click 75 million boxes and fill out all these different questions to be able to satisfy insurance just to get paid, as long as they don't deny you on the back end. The reality is that there's so much that you have to get through, right, in each patient visit. And as doctors are squeezed into smaller and smaller windows, which they can do that becomes difficult. And so if either the doctor doesn't know about the ejaculation problems or with the PSA or what have you, but honestly, in my practice, I always check a second PSA. That's first of all, that's always something that's done. And actually,
and how long after?
I would say I at least have them abstain from ejaculation for a week before. And I would say usually I'll probably wait a couple of weeks and just kind of let things shake out a little bit just to see, and I guess the other thing that I didn't quite get to before you posed your question was if somebody is a cyclist or a motorcyclist, certainly remember when you sit on saddles, you're basically sitting on a skin tissue that's right superficial to the prostate. And so you can put some pressure on there. And I have seen guys who've abstained from riding for a little while and their PSAs kind of come back down, right? And so, from that standpoint, we always check a second blood test. I think in this day and age, even though the U.S. is a little bit slow to kind of pick up on a lot of medical innovation as compared to Europe, I think most people would probably still potentially order an MRI prior to doing it. Mainly because you can find little lesions in the prostate that could potentially be concerning. And remember, in the standard biopsy is really just done in a template fashion with an ultrasound. First of all, you cannot see prostate cancer with an ultrasound. Number two, if you do just a template biopsy, again, you're poking 12 little specific areas with a needle. The best way that I have to describe that to patients is that if you think about an apple, you poke at 12 little specific spots in the apple, and you may find bad spots, you may miss bad spots, you may, you're not taking out the whole gland. Obviously, we're not going to do that because we already talked about earlier in the show that if I take out your whole gland, even if I spare your nerves, there's still an 80% chance you're never going to penetrate again.
Right.
That's a problem. There's significant side effects associated with surgery, to where we reserve that for the people who actually really need it from a cancer control standpoint. But the reality is that I think the MRIs are valuable because you avoid poking, prodding. Plus, it does give you some vision. Because if you have lesions on your MRI, similar to if you had a lesion on your kidney, we can use actually special technology nowadays that allows us to take your MRI pictures and specifically fuse that with a live ultrasound image and specifically target those little lesions. And so it's a much more calculated biopsy. Now, usually I think the best studies that are out there these days show that if you do the standard template fashion, the 12 little spots, and any little lesion that you found on the MRI together is better than either alone. So I usually, again, if somebody comes in with any type of elevated PSA, I always go through those screening questions with them. Certainly getting a urine culture and checking for infections, and or checking for symptoms of an enlarged prostate. Because if somebody has, there's a thing called an AUA symptom score, which is basically 7 different characteristics about your voiding habits, ranked 1 to 5. It's things like frequency, urgency, the sensation of completely emptying when you go to the restroom and not having to go to the restroom again very shortly, how many times you get up at night to pee, this type of stuff. And so I always have them fill out one of those surveys as well, because for me, if your survey is 35 out of 35, on your urination score, because you're struggling, I'm thinking UTI, I'm thinking, enlarged prostate, I'm thinking, less likely cancer. And remember, your PSA can still be climbing up a little bit on you, even with just an enlarged prostate. So, and or infections, right? So, again, usually always repeating the blood tests at least a couple weeks later, at least with education about ejaculation and avoiding any saddle activities like motorcycles or bicycles. And then, usually in my practice, I tend to promote the use of an MRI first prior to any poking and prodding, because I think, number one, it avoids invasive procedures if we don't necessarily have to. Now, again, the caveat to that is that an MRI is not perfect. There is still about a 20% chance you miss really, really small lesions, less than 1 centimeter, but it's better than no vision at all. And so, again, because the ultrasound, when you do a biopsy, usually it's done ultrasound based, and ultrasound cannot tell you, yes, there's cancer, no, there's not. And so you're really just poking the apple and sampling the 12 spots, but whether or not those spots are the bad spots or not, you don't really know until you get the pathology.
Right.
So yeah, always rechecking and making sure, double checking the blood test. Cause again, I've even seen where we've checked it a couple different times and it goes up and down, and, it kind of does a little yo-yo stuff, which is a hard, I mean, medicine is not a perfect science, right? So there's no, and that's where, to some extent, again, you kind of asked about direct care and that type of thing. I think direct care allows for more individualized medicine without the constraints of insurance regulation and what the insurance will allow you to get performed, right? And so from that standpoint, everybody's different. So why would we slap, the same set of constraints on each individual person? When we all have different genetics, we all have, different ways that we're raised, we all have different environments that we're exposed to throughout our lives, and that makes medicine, to some extent, a little bit tricky sometimes.
Yeah, and that's why a personal relationship with their physician, like you would have in direct care, is so important. So one other comment or question for you, actually. So a prostate exam in itself can increase PSA, correct?
That's a good question. I don't know. There's a variety of studies that have tried to capture that. I mean, I think it's kind of the same as well as the ejaculation, right? To some extent, because at least in theory, because if I'm sitting there pushing on your prostate, the reality is I think from an ejaculation standpoint, kind of what happens that causes potential increase in PSA is that, remember, after the sperm dumps into the seminal vesicle in the prostate, that dumps into the urethra, and then the pelvic muscles contract to be able to kind of push it out the end of the penis and do the true ejaculation portion of the process, right? And so, from that standpoint, that squeezing of the area, you can kind of almost think of it as kind of milking some of the components out of the prostate, right? And so that's where PSA comes from. It's prostate specific antigen, right? And so if you're again, that's where compression of the bike seat or motorcycle seat, or
Right.
kind of the compression of the muscles in the pelvis from ejaculation, or alternatively, I think if somebody's really truly mashing on the prostate, the run of the mill quick finger in, just kind of feeling for nodules and stuff. I mean, unless you're kind of truly kind of mashing on the prostate, I don't know if that's going to do much. And I think actually the most recent study I've seen on that part, they kind of suggested against. But again, in theory, especially if you're, really, I mean, because for prostatitis, sometimes we'll do, kind of prostate massage, right? And try to kind of express the infection, express the nastiness out of the prostate to kind of relieve some of the symptomatology, right? And so if you're doing that, I think that's certainly a different story than a quick kind of finger in and swipe around and exit. But I mean, again, sometimes strange things happen or different things happen. So
that's why repeat testing is so important.
Correct.
Yeah. I love it. Wow.
I
tell you what,
one data point for sure.
Yeah, right. Yeah, that's awesome. Well, Dr. Wallen, wow, we got to have you on again, because we have already been talking for an hour and 10 minutes. And this is stuff we just, our listeners and viewers like this information. And of course, we're passionate about it at our pharmacy, because we just talk a lot about this stuff when it comes to hormone replacement. And we just barely touched on men's hormone replacement with you. And we could talk I could talk a whole day about that. I'm very passionate about it, and it sounds like you too. So maybe we'll have to have you on again and talk about that subject. I really, really appreciate it. So we're going to wrap up our session here, or another show. But yeah, we definitely have to have you on. So let's keep in touch. And listeners and viewers, you've been listening to Health Solutions with Shawn and Janet Needham. And Dr. Wallen, thank you for being on today. And thank everybody for tuning in. Listen to Health Solutions with Shawn and Janet Needham. We'll see you Monday, 1 to 2 p.m. Eastern or Pacific, as we stream live on my Facebook and the Mosley Professional Pharmacy's YouTube site. Thank you so much for listening.